Hello friend, this is a case of Clipless Laparoscopic Cholecystectomy. This is a young girl and she has multiple gallstone and we will perform clipless cholecystectomy by the help of harmonic scalpel. So, in this we will not use any hemolock or titanium clip, but we will do cholangiogram so that we will confirm and we will perform it. So, these are the two LEs forceps applied either side. And the purpose of these LEs forceps is to invert the crease of the umbilicus, so that we can put varus needle and we can create pneumoperitoneum, and after that we can put the first, that is the optical port, that is for telescope, and these are the two LEs forceps applied to invert the crease of umbilicus. Now this is the 11 number knife which is stabbing the inferior crease of umbilicus. This is very thin abdominal wall. So, we will guard approximately 6 centimeter of the varus needle and going perpendicular to abdominal wall, but oblique to the body, varus needle is introduced. So, you will get two click sound, first is due to the rectus and another is due to peritoneum. So, this is the varus needle, and here we can see that you have to be careful, and this is the first click and this is the second click. So, it is in. After that we will take the syringe, we will perform irrigation, suction and hanging drop test. In the disposable varus needle there is one indicator also, and this indicator to show you green. In the ethicon varus needle, if you are inside the abdominal cavity, it will show you green color. This is the green color, that means it is in the free cavity. If it is red color, that means it is in the abdominal wall. So, you can see during introduction it is showing you red color, and while you are passing it will show you red color, if you will see that. So, again I have taken it out to just to demonstrate you how the color changes. So, look at this, while you are introducing, this is red color, and once you are fully in the abdominal cavity, then it will become green color. So, you should be perpendicular to abdominal wall, but oblique to the body. It should not be directly vertical to the body, otherwise there may be chances that you can enter into bowel or the iliac vessel or the aorta. But if you will point it towards the anus and you will keep it perpendicular to abdominal wall, absolutely safe, there will be no any chances, and it will not go to pre-peritoneal space also. So, this is irrigation test, and now this is suction test, and now you can do hanging drop test, or this is the hanging drop, you will drop it and then lift the abdomen, it will be sucked in, and there is a ball which will sink also. After that, tubing of the insufflator will be attached, and the flow rate right now with the varus needle is 1 liter per minute. So, we have used preset pressure 15, and slowly actual pressure will be single digit within first 5 seconds, and slowly it will increase. So, we can see here homogeneous distension is started and abdomen is insufflating with the carbon dioxide. As we know that CO2 is 200 times more absorbable than oxygen and 20 times more absorbable than room air. So, once you will remove the CO2 at the end of the surgery, within 24 hours there will be no more CO2, it will be absorbed by the peritoneum. And the purpose of CO2 is, you know, that it has a minimum chance of creating the air embolism, because even if it enter into the vein, as long as your flow rate is 1 liter per minute, there is no chance that CO2 can create air embolism. So, we are waiting for distension, and you can see there is a homogeneous distension started, and as we know, minimum amount of the gas required to create the pneumoperitoneum in adult abdominal cavity is 1.5 liter and maximum is 6 liter. This is a young female, so she will not take more than 2.5 liter to reach the preset pressure 15, and we are waiting for the actual pressure to reach to the preset pressure. So, here we are using a striker pneumoflator that has a very good quadromanometric indicator, and this pneumoflator has CO2 warmer itself. So, it is heating the CO2 at a temperature of 37 degrees centigrade, and this insufflator has a lot of microprocessor controlled, a lot of indications. So, the occlusion, or if you are going in the preperitoneal, or if it is obstruction, it will tell you a lot of information. So, it is a very good insufflator, and it has a maximum flow rate 45 liter per minute possible. So, even in the bariatric surgery or colorectal surgery, and even it has a pediatric mode, and in the pediatric mode flow rate will be 0.1 liter per minute per year of the age, and maximum amount of gas you require in pediatric patient is 200 ml into the age of the patient in year. Like suppose 1-year-old child will take 200 ml, 2-year-old child 400 ml, and this insufflator has pediatric mode, then the high vessel harvesting mode, then high flow mode, bariatric mode. So, these all modes are there. So, this is very safe, and it has a CO2 warmer. If you will touch this tubing, you will see it will hot, because it is warming the CO2 and then putting it inside the abdominal cavity. So, we are just about to reach the actual pressure is about to reach the preset pressure, and then we will take the varus needle out. Slow insufflation is always better. However, the eye of the varus needle does not allow more than 2.5 liter per minute to flow, but that 2.5 is also not good, because if accidentally going into the vein, even with the CO2, if the flow rate of CO2 entering into the vein is more than 2 liter per minute, then it can create air embolism. So, you should be always better to maintain a slow insufflation. So, now it is over and varus needle is taken out. Now, we will take 11 number knife and enlarge the incision either side to make it 11 mm. After that, we will dilate the obliterated vitreointestinal tract with the mosquito. You can just little bit stretch the skin up to the rectus. And this is the first trocar which you can introduce, keeping it perpendicular to the abdominal wall. As soon as you will enter inside the abdominal cavity, you will have hissing sound. This is hissing sound here, because there is an eye at the tip of the trocar. Through that, hissing sound will be visible. After that, this is the eye on the trocar. You can see a small opening that create the back. It is a cylinder, and once the CO2 passes through this cylinder, it will give you hissing sound. Now, the cannula is little bit cleaned, so that if there is any betadine or any glutaldehyde, then it will be cleaned, and the purpose is it will not make your telescope dirty. So, now the telescope is introduced, and you will have the first view of the gallbladder. You will look to the inferior surface of the liver, You should also see that fundus is projected or not, and this is the GP sternum here. So, now the second port will be just below the GP sternum and little towards the left, and this is also 10 mm incision. Always better to give incision in the Langer's line. So, here Langer's line is horizontal and only a skin should be cut. And now, it is puncturing the membranous part of the falciform ligament, and then you will reach to the right. After that, third port will be introduced mid-clavicular line just below the costal margin, and for the third port you can ask your resident who is standing on the other side. Initially, diagnostic laparoscopy should be performed by introducing one atraumatic grasper, and you can lift the lever, you can lift the gallbladder, and you can do initial diagnostic laparoscopy. After that, this is the third port, that is mid-clavicular line just below the costal margin, and this port you can ask your assistant who will hold the fundus of the gallbladder. Patient head is going up and right is going up, so that you will have the bowel moving away from there, and then vision of the calots also will be better. So, these two ports will be 5 mm, and you have to cut along the Langer's line. Full thickness of the skin should be cut, and after that you will hold the trocar. You can give your assistant to hold the trocar like a pistol. This is the way how to hold it, and the index finger must be pointing towards the sharp end. And here assistant is introducing the third port. Now, fourth port will be introduced 7.5 centimeter lateral and 7.5 centimeter below the third port over the anterior axillary line, and all in the book it is written at the level of umbilicus in the anterior axillary line, and this will be the also 5 mm port, and that will be used as a fundus grasper. So, you can see all the 4 port is introduced. After that, you can put a grasper and you can do the diagnostic. A standard laparoscopic cholecystectomy is a 4 port cholecystectomy, in which the right hand will be epigastric port and the left hand of the surgeon will be mid-clavicular line on the right side for Hartmann pouch, and the fourth port, which is on the anterior axillary line, will be held by the assistant. So, here Hartmann pouch is held, and this is the harmonic scalpel, and we are using the posterior peritoneal dissection by giving anteromedial traction and always above the Rovier sulcus, and this is the visceral peritoneum of the cystic pedicle is separated by the harmonic. This is anterolateral traction to do the anterior peritoneal dissection, and here this is the cystic duct. So, this is the posterior peritoneum, and all we can see that this peritoneum, once you will separate, then the cystic duct will be clearly visible, and we have to make anterior and posterior window. This is the window in between the duct and artery, and you can always dissect parallel to the tubular structure. So, now this is the window is formed between the duct and artery, and this is a very simple cholecystectomy. So, here we can do clipless, This is the window clearly made. Now, this is the seizures which is cutting half of the lumen of the cystic duct. Little bile is coming, and now this is a cholangiogram forceps which we will introduce, and with the C arm we will do the cholangiogram. So, here this is the cholangiogram. You can see that there is no dilatation of the intrahepatic biliary tree, there is no dilatation of the CBD, and entire CBD architecture is visible. Duodenal bulb is also visible and cholangiogram is normal. However, you can do the ICG. Nowadays, we do ICG cholangiogram mostly because you don't need to bring C-arm, you don't have to wear the lead apron. And here directly harmonic is sealing the cystic duct. At that time, you should relax the Hartmann pouch so that sealing will be better. And it is sealing and cutting together. So, artery is sealed and cut, you can see absolutely no bile leak, and then this duct is cut. After that, this is the artery. In clipless cholecystectomy, artery also you can take by the harmonic. But while you are taking the artery, you should relax the Hartmann again. If you will keep it a stretch, it will bleed. So, artery is also done, and after that we will separate the gallbladder from the liver. So, clipless, and you can see through towards the gallbladder also there is no bile leak. Bile is also not leaking from the gallbladder side, and that way laparoscopic cholecystectomy clipless can be performed. Now, anteromedial anterolateral traction will be given, and the entire gallbladder will be separated from liver only by harmonic scalpel. So, some people they use ligation also. Ligation also can be used for clipless cholecystectomy, but to separate the gallbladder from the liver, harmonic is better. So, most of the time people they use harmonic scalpel. So, this is over and gallbladder is removed. So, thank you very much for watching this video. This was just a simple case of laparoscopic clipless cholecystectomy by harmonic scalpel.